Hi there, my name is Karrie Meier, and this is my part 3 of developing a change project. This is for SIM 421 through American Sentinel University. My main two references are our textbook, the 9th edition, Leadership Roles and Management Function in Nursing, the Theory and Application by Markey and Huston, as well as an article by S. Giddings called Understanding the Behaviors Experienced by Individuals During an Organizational Change Efforts, a Delphi analysis utilizing the 5-stage grieving model. This is just an outline taken from our rubric. I will identify a change management theory and discuss how it is relevant to the change process that I discussed in part 1 as well as part 2. And then I will identify the principles related to the change management theory and identify how these are associated with the change project. This is just a recap of my change project. I chose bedside shift reporting, and just to reiterate, it's to increase patient safety, to increase the accountability between nurses, establish the trust, and increase patient satisfaction. So we're going over things like the checkoff list, which I described in part 2 with IV drips, wounds, drains, saying that goodbye and hello, involving the patient, updating the whiteboard, so on and so forth. I chose to focus on 3 main types of change management theories. The first one being Lewin or Levin, the second Cotter, and the third one, which I'll spend the most time on, is the Kübler-Ross grieving process, actually. So firstly, Levin or Lewin has a nice little diagram in our book on page 191, and it has to do with the unfreezing. So that's when we gather the data, we diagnose the problem, decide if a change is needed, make others aware, and then we go into stage 2, which is the change, it's the movement. This is when we develop a plan, set goals and objectives, identify areas of support and resistance, we set those targets, we implement the change, we develop all the strategies, there's some evaluating in there as well. And then thirdly, we refreeze. So we make this permanent and we support it so it can continue to grow and flow. Secondly, we have Cotter, and I took this from the Giddings article. We establish that urgency, we develop the coalition, develop the change, make your buy-in, empower the action, generate short-term wins, never letting up, which is kind of scary because at some point a change can be bad and you need to let up. And then lastly, the incorporating changes into the culture. So that's kind of the end game with all of those steps. I like step 8 is how we change the culture. Like, this is your expectation that we will be doing bedside shift reporting. This is the norm. And that's how we make changes happen. And then lastly, the Kübler-Ross, which I will get to on the next slide. Before doing this assignment, I looked at the Kübler-Ross, and I was like, what does the staging of grief have to do with the change theory? That I didn't see any correlation whatsoever. And then as I took a deeper dive, I realized that, wow, they really coincide really well. And I have a graph on the next page that just flows perfectly. So why is this relevant? Because we have those nurses, usually seasoned, but they can be newer nurses that just are like, why we've always done it this way. Why do we need to change this? Why can't we do this in the nurses station? Why is this important? I already have so much on my plate. Why are they making me do one more thing? I don't have time for this. There's all of that like negativity with changes generally, because change can be scary. And I'm looking at the stages of grief and realizing that change can be a loss, and you're looking at all of these things, like they're resistant, they're disrespectful, they're frustrated, they can be irritable. If we feel that things are out of our control, I think of how our patients feel when we tell them what they can eat, when they can eat. I need to see your poop, I need to collect your pee. All those things of control are taken away, and we see their frustrations. And then we just take a little bit of our control, because nurses are generally type A control freaks. That's just how the beast is. Any change can be, a huge frustration. And then as far as the depression part goes, the fear, the fuzziness, the loss of sense of humor, which I feel like humor is just how we get through the day most of the time. And then when we get to that acceptance part where we have the compliance, and then we take ownership of the bedside shift reporting, and we feel secure, we're comfortable in this setting, we know what we're doing. This is, again, part of the culture. It will be a good thing. This continues with the Kübler-Ross, and this is the graphic that I mentioned, how the denial, anger, bargaining, depression, and acceptance flow with all those emotions. And when you have a change theory or a change project, this can happen as well. And there's even that this is where we're excited, this is where we have resistance, and this is where we have the enthusiasm to be part of the culture. So with this, try to keep things positive. We want to ensure that the nurses, that this is a positive change. We want to make sure that the timing is right. We don't want to feel that we have taken away their power. We do need to increase their knowledge base. This is all in our textbook on pages 331 and 332. We need to give them the unique perspective. We also need to understand their unique perspective. It's one thing if we have a manager looking down saying, you need to do this, whereas if it's coming from a committee made of bedside nurses, floor nurses, then it's coming from us. Like, this isn't a higher up telling us what to do. This is us telling us what we need to change. And then we have to have the desire for the change. And that is where you can't force that into somebody. So we're trying to keep this positive. And then if we continue to meet resistance, we go on to that next point there, and the annual reviews. If you're not compliant, maybe it will affect your annual review and therefore affect your raise, because these are your expectations. This is maybe worked into your job description at this point. And then bring it back, keep it positive, that it's a reminder that why are we doing this? This is all about the patient safety. We look back on those numbers, the 44,000 to 98,000 deaths, preventable deaths a year that could have been prevented from these errors. Like, just think of how many errors, how many lives we can save by doing the things that we should be doing anyways. And then again, these are the 3 change management theories that I've chosen, and these are basically the principles. Not to reiterate them again, but here they are again. And then how are these associated with the change project? So we want to have the nurses, not just the committee nurses, but the floor nurses. We want to hear their ideas. We want to have that open form of communication. We want to communicate with them how they need to be communicated with. We need to have a similar vision. Our hospital is a Catholic hospital, and they have the mission, and it's all about being competent, having joy, and there's more. But we need to kind of also, educate, change the culture like we mentioned before. We need to look at maybe the evidence-based practices and those facts that we need to move forward with the nurses. We also need to support the nurses. We need to acknowledge that this is a stage of grief. We also need to, looking forward into the future, with the mission, we need to mentor the future nurses and students as well. And in conclusion, this is a spin-off of part 1, part 2, and then this is the end of part 3. Like, just to reiterate, why do we need this change? It's all about patient safety. Even if we don't see, like, our hospital doesn't have hardly any patient deaths that are not explained. We have, other than like the DNRs. I work on a heart floor, so there's usually a reason. But if it's a safety incident, if it's one of those like Sentinel report type of things, you should see that drastically decline if you add in bedside shift reporting. What we could see at our hospital is the decrease in incident reports. So those are generated daily, and they are ranked 1, 2, and 3 by importance. Like, what needs to get roller clamps are just part of. They happen every day, unfortunately, and hopefully they don't have a negative patient outcome. But what can we do to make a change with a roller clamp? I feel like that's always my example. And then staff accountability and trust. This is between the nurses as well as the staff, and it will trickle out to the CNAs, the dietary, the physicians, your charge nurse, your director. I mean, board of directors should love this. We talked about that in part 2. Insurance companies should love this. The community should love this. It will be a good thing. And then to increase patient satisfaction. So again, it decreases the patient's anxiety. They are involved in their care. They're getting a little bit of that control back. We're making sure that they're not in pain, because that's one of the biggest complaints. and hopefully they get educated. A lot of education happens during that shift change, and they can get out of the hospital and live a healthy life, or they can make the decision to go comfort measures and live out the rest of their life comfortably. It could go either way, but the choice is ultimately theirs, and just to give that power back to the patient. And then these are my references. I have our textbook as well as that article by Giddings. And I believe that is it. Thank you.